A patient aspirated barium during a VFSS. Now what? For some SLPs and radiologists, this might mean the study should end. For other SLPs, this means the study is just getting started. It's well understood that a VFSS should tell us why a patient aspirates and which strategies can successfully reduce risk of aspiration. But should we be extra concerned if barium gets into the lungs? Today I'm going to discuss 3 factors to consider when deciding whether or not to push on with the study or halt any more barium trials in favor of protecting the patient's lungs. Let's dive in.
I'm Theresa Richard. I've been a medical speech pathologist for 15 years. I'm a board-certified specialist in swallowing and swallowing disorders. I'm the founder and CEO of the MedSLP Collective and MedSLP Education.
Number 1. The type of barium contrast matters. Barium is an inert material, meaning it's non-toxic. However, that doesn't mean it's completely harmless. Different contrasts may come with different risks. Veribar, for example, is a type of standardized barium that is 40% weight per volume, meaning 40 grams of barium sulfate is used to make up a total volume of 100 milliliters of liquid, or the barium consistency is 40% barium sulfate. Other barium contrasts may be higher in barium concentration, which carries a greater risk for pulmonary damage if aspirated. Aspirated barium can remain in the lungs for several months, or potentially even for the rest of that person's life, which will impact future chest imaging. In severe cases, barium aspiration can lead to respiratory failure or even death. Barium sulfate, however, is viewed as having a lower risk of causing pulmonary edema than water-soluble contrast like gastrogafin. Unlike water-soluble contrast, some barium may be taken out of the lungs through phagocytosis and other cellular events that happen at the alveolar level. If enough barium is aspirated, it can clog small airways. In cases like severe or end-stage emphysema, where the alveolar surface is already at a minimum and there's no real alveolar reserve, barium aspiration can cause pulmonary issues. One SLP friend of mine shared her experience with GI and radiology when it came to barium swallow studies and managing barium aspiration. If there was a patient who had orders for an esophagram, the radiologist would often page my friend if they had any concerns for dysphagia whatsoever. Sometimes they would put in orders for a swallow eval, and if there was any concern for aspiration, they would either drop a tube into the patient's esophagus and complete the study that way if necessary, or cancel the study completely. This was because of the high risk of respiratory failure with the high volume barium contrast they used. Barium for an esophagram is usually thicker and meant to coat the lining of the esophagus, making it more difficult to clear the lungs if aspirated. This was how she first learned about the differences in various barium contrasts and used the fact that Veribar had a lower barium sulfate concentration to leverage her request for the hospital to purchase Veribar products. Number 2, consider age and dysphagia severity. While age is becoming less of a determining factor for a lot of medical intervention, particularly with the advancement of medicine and technology, age should still be considered when assessing the risks of barium aspiration, particularly when multiple comorbidities are present. Case studies have found that elderly patients with multiple comorbidities are at greater risk for pulmonary injury and respiratory failure when barium is aspirated. For example, there are 2 case studies that involve 70-year-old patients who aspirated barium. One patient was discovered to have barium remaining in his lungs from a VFSS that was completed several months prior to the chest X-ray that captured the aspirated barium. This was an incidental finding. He had presented with no symptoms and remained healthy despite living with some barium in his lungs. A separate case study reported on a 79-year-old who was evaluated for an unintentional weight loss and dysphagia. During the VFSS, he aspirated a large volume of barium during rapid sequence tasks and eventually went into circulatory shock, cardiac arrest, anoxic brain injury, intubation, hospice, and eventually death. This patient had multiple comorbidities and was deconditioned. His dysphagia was also severe enough to lead to large volume aspiration with an inability to clear the aspirated material from his lungs. According to Dr. Hundemer and colleagues, barium studies should be used judiciously in elderly patients with multiple comorbidities and altered head and neck anatomy, as this population is more likely to endure negative consequences of barium aspiration. One study published in 2016 that looked at the incidence of pneumonia after VFSS found that only 1% of the cases they retrospectively reviewed had VFSS-related pneumonia. The authors of this study reviewed 696 VFSS cases. Not all involved aspiration. Among those cases, 15 patients were diagnosed with pneumonia. The patients in the pneumonia group tended to be older and had higher aspiration rate on the VFSS than those in the non-pneumonia group. They concluded that the 72-hour incidence of VFSS-related pneumonia was 1%, and that old age and severity of swallowing difficulty were associated. Overall, older age, dysphagia severity, and volume of aspirated barium are 3 big contributing risk factors to respiratory decline secondary to barium aspiration. When these risk factors are present, it might be worth considering an endoscopic evaluation of swallowing as a safer alternative to barium studies. Now, I've shared 2 case studies with patients who are older, but I now want to share a case study involving a woman in her mid-50s. This woman had stage 4 tongue cancer and long-standing dysphagia. During her VFSS, she aspirated a large amount of volume and rapidly developed hypoxemic respiratory failure from the chemical pneumonitis. She immediately received supportive respiratory care, including a 100% non-breather mask, chest physiotherapy, a percussion vest, and an a cappella device, or what some people refer to as the pickle, to promote cough and barium clearance. Within 48 hours, her respiratory status improved and she no longer required any supplemental oxygen. By the time she was discharged from the hospital, her chest x-ray only showed small amounts of barium in the left lower lobe. This is another example to show how different outcomes can occur with barium aspiration, age, and comorbidities. I'll be posting other videos just like this one that you won't want to miss, so make sure to hit that like and subscribe button and turn on the notification bell. Do you have any specific questions about barium aspiration? Leave a comment below and tell me about it. We'll be sure to get your questions answered as soon as possible. Make sure to stick around to the end to claim a freebie or 2. What do ASHA and the American College of Radiology VFSS guidelines say about barium aspiration? Both SLPs and radiologists have VFSS practice guidelines. Only the American College of Radiology, or ACR guidelines, specifically mention aspiration. However, ASHA guidelines do highlight the importance of getting a sufficient number of swallowing attempts and assessing compensatory strategies. To quote the ACR VFSS practice guidelines, radiologists are told that if aspiration occurs, the patient's response to aspiration and ability to clear the aspirated materials and his or her response to protective and therapeutic maneuvers should be assessed wherever possible. ASHA's guidelines state that a complete VFSS requires a sufficient number of swallowing attempts to A. Make a clinically informed decision about route of intake, consistency of oral diet if appropriate, exercises to improve swallowing functioning, and compensatory techniques to maintain patient safety while consuming an oral diet. And B. Determine the need for additional assessment and interventions through interprofessional team referrals. This is important to know because we should understand what our organizations state in their guidelines, and we can use the ACR guidelines to prompt discussions with radiologists who have a strict rule about ending the study as soon as a patient aspirates. I love how the American College of Radiology recognizes the importance of assessing the response to aspiration, ability to clear aspirated materials, and their response to protective and therapeutic maneuvers is important, and that the simple presence of absence of aspiration is not the sole purpose of the study. My good friend and colleague Lauren Hermann has shared her story multiple times in presentations and on my podcast about the first time she encountered a radiologist who didn't allow her to start a VFSS with thin liquids because he was concerned the patient would aspirate, telling her that he would end the study as soon as the patient aspirated. She was taken aback at first and unsure how to respond to this difference in practice standards. But at the same time, she wasn't sure what the literature said about barium aspiration, and if his concerns were 100% valid. Apparently, this was his rule for all VFSSs, not just this particular case. This prompted her to initiate survey research to further investigate the VFSS practice preferences between radiologists and SLPs, which wound up getting published in Clinical Imaging. This also pushed her to dig into the research and discussions around these differences, including barium aspiration and what the effects were. She wasn't surprised to discover that there was a statistically significant difference between the radiologists and SLPs that completed her survey when it came to whether or not a study should end as soon as a patient aspirates barium. The radiologist respondents were overall in agreement that the study should end upon initial aspiration event, whereas the SLP respondents overall did not agree that the VFSS should end as soon as aspiration occurs. Understanding the concerns radiologists might have, in spite of the fact that their own VFSS practice guidelines clearly state that further assessment is warranted when possible if aspiration occurs, help Lauren to better approach her radiology colleagues by speaking their language and leaning on research. Having these discussions can build better bridges between radiologists and SLPs. If you'd like to see the survey research, you can click the link in the comments below. Overall, each patient requires individualized clinical decision-making when doing a VFSS and considering aspiration risk. Remember, consider their age, dysphagia severity, comorbidities, volume of barium they will be consuming at once, barium concentration, and what the main purpose of the study is. Make sure to check out episode 123 on the Swallow Your Pride podcast, where Lauren, Hermann, and I discuss the common barriers between radiologists and SLPs, important considerations, and the survey study she and her team created. Once you finish that episode, hop on over to episode 178 to see what the survey results were, and my discussion about these results with Lauren and radiologist co-author, Dr. Benjamin Mervack. You can find the links to these episodes in the comments below. Want more support and resources to help improve your VFSS protocols with your radiologist team? We have a robust and vibrant community of SLPs and mentors to help you out over at the MedSLP Collective. Head over to medslpcollective.com/join to become a member today and strengthen your collaboration tomorrow.